Dear student, the topic of this video is physiological basis of contraception. Regarding the classification of methods of contraception, we can divide it into two types. One is a temporary methods of contraception, another is a permanent method. The temporary methods can be of different types. One is a barrier method, for example, the condoms or the diaphragm. Natural contraception, the intrauterine contraceptive devices, and the steroidal contraceptions. Regarding the permanent method of contraception, there may be the tubectomy in case of female and the vasectomy in case of male. Whether any contraceptive method it is effective or not, that is expressed by one index, that is the Pearl index. The failure rate of any contraceptive is calculated in terms of pregnancy rate per 100 women years of use, HWY. So how we can calculate it? You can see, suppose I am studying 100 women for 2 years, and out of this 100 women, 20 gets pregnant after using this type of contraceptive method, one type of contraceptive method. So number of pregnancy will be then the 20 into the 12, that is the year, number of months in a year, divided by number of women, total number of women, that was 100, and into the number of months, how many months we have studied them. So it is 24 months into 100. So you will get a number. If the pregnancy rate is below 10, the effectiveness of particular method is considered to be high. If it is more than 20, it is said to be less. The following are the effectiveness of commonly used contraceptive methods. So we all know how actually the fertilization and implantation of the blastocyst happens. In my previous video, a detailed discussion was done on it. So we know that our entry of sperm will be through this female genital tract, and the entry of ovum will be in this direction through the fimbria. At the ampulla there will be the fertilization, and at the wall of the uterus there will be implantation. So contraception means I have to prevent any of this process in order to prevent the pregnancy. Either I can prevent the entry of sperm, or either I prevent the ovulation process, or either I prevent the implantation process. So anything in this pathway, blockage in this pathway will cause the or inhibit the pregnancy. Now we will see all these methods, what is the physiological basis of their function. First come to the barrier method and IUCD. So barrier method, these methods prevent sperm deposition in the vagina or prevent sperm penetration to the cervical canal. The entry point, it is blocked. So the mechanical methods, in case of male it is condom, female it is the condom, diaphragm or the cervical cap. Chemical, some vaginal contraceptive creams are there, nonoxynol 9, jelly, some foam tablets can be used to prevent the entry of sperm, and the combination used or combined use of this mechanical and chemical methods. Most commonly used method is the condoms. Condoms are made up of polyurethane or latex. Now there are few advantages and disadvantages of each and every methods. So advantages is it is cheaper, no side effects, easy to carry, and most importantly, it also gives protections against the sexually transmitted diseases like gonorrhea, chlamydia, HIV, HPV, and also the pelvic inflammatory diseases. So it also reduces the incidence of tubal infertility and ectopic pregnancy, protection against cervical cell abnormalities, useful where the coital act is infrequent and irregular. Now few disadvantages are there. And we can see that the failure rate here with the help of Pearl index, it is 15 per 100 women year. So may accidentally break or slip off during coitus, inadequate pleasure, allergic reaction to discord after one coital act. Another method, these are the natural methods, that is the rhythm method. This is the only method approved by the Roman Catholic Church. The method is based on identification of the fertile period of a cycle to abstain from sexual intercourse during that period. So, we have to identify a fertile period, the most fertile period in the menstrual cycle. We know the cycle duration, a regular cycle duration is from 1 to 28 days. Among these days, which period is a fertile period, they have to determine it, and they should abstain from sexual intercourse during that period. So how can we determine this fertile period? Three methods. One is a calendar rhythm, recording the previous menstrual cycles, noting the basal body temperature rhythm. We know that after ovulation there is increase in basal body temperature. On noting excessive mucoid vaginal discharge, we know there is a definite change in the cervical mucus before and after ovulation. So three rhythm, calendar rhythm, temperature rhythm and mucus rhythm. By these three rhythms we can determine the most fertile period of a cycle. The users, so first the users of the calendar method, they obtain the period of abstinence from calculation based on the previous 12 menstrual cycle records. So they have to observe, they have to calculate the duration of the their period or menstrual cycle throughout 1 year. Okay, 12 menstrual cycle, that is through 1 year they have to notice their menstrual cycle, and the fertile period will be determined in this way, that is the first unsafe day will be obtained by subtracting 20 days from the length of the shortest cycle. So out of this 12 menstrual cycle in the year, there may be one shortest cycle, say it is 22 days. So you have to subtract the 20 from the first unsafe day, and the last unsafe day by deducting 10 days from the longest cycle. Say the longest cycle is the 30 days. Okay, so you have to subtract or deduce the 10 days from the longest cycle. Okay, so that is, say it is 20 days, so from 2 to 20 days, so there should be a period of abstinence. Now, users of temperature rhythm require abstinence until the third day of the rise of temperature. We know that post ovulation there will be rise of temperature, so abstinence until the third day of rise of temperature. And users of mucus rhythm require abstinence on all days of noticeable mucus for 3 days thereafter. So we can see that the failure rate is very high, that is 20 to 30, 100 women year. Advantages are no cost, no side effects, but it is very difficult to calculate the safe period reliably. Needs several months training to use these methods. Compulsory abstinence from sexual act during certain periods. No, not applicable if the cycle is irregular or the subject is having lactational amenorrhea. Another natural method is the coitus interruptus, that is withdrawal of penis just before the ejaculation. So here is a failure rate is also high, that is 2700 women year, and no appliance is required, no cause. These are the advantages. Disadvantages, it requires sufficient self-control. The women may develop anxiety neurosis, vaginismus or pelvic congestion. Chances of pregnancy is more, because precoital secretion may contain sperm, and accidental chance of sperm deposition into the vagina. So this is another natural. Another important thing we have discussed in lactation, that is breastfeeding. Lactation gives a kind of protection in lactating mother, that is a lactational amenorrhea. So prolonged and sustained breastfeeding offers a natural protection to pregnancy. This is more effective in women who are amenorrheic than those who are menstruating. If the lactating mother is not having menstrual period, then it is effective. The risk of pregnancy to a woman who is fully breastfeeding and amenorrheic is less than 2% in first 6 months. Otherwise, the failure rate is high. And thus, during breastfeeding, additional contraceptive support should be given. So this point is important. During breastfeeding, although we know that lactation gives a kind of protection, but you never know, menstruation is not happening, but there may be ovulation, because ovulation precedes few cycles of menstruation. So it is required to use additional contraceptive methods, and in the form of condom, IUCD, where available to provide complete contraception. When the woman is fully breastfeeding, a contraceptive method should be used in the third postpartum month. And with partial or no breastfeeding, she should use in third postpartum week. So after delivery, from the third week onwards, if the mother is not breastfeeding or even partially feeding, then should start using the contraception. Now come to the another method of contraception, that is your IUCD, that is IUD, or intrauterine devices. So this IUCD, what is their mechanism of action? How are they preventing the fertilization and the implantation? They are a non-specific inflammatory, there is a non-specific inflammatory reaction along with biochemical changes in the endometrium which have got gametotoxic and spermicidal property. So if IUCD is inserted into the vagina, so there will be some non-specific inflammatory reactions and biochemical changes in the endometrium. These changes may prove gametotoxic or spermicidal. Now, lysosomal disintegration from the macrophages attached to the device, they liberate the prostaglandins, which are very much toxic to spermatozoa. Macrophage cause phagocytosis of the spermatozoa. So we are inserting a foreign body here. So some kind of immune reactions will be there, and there will be release of some chemical substances. They have the spermicidal activity. There may be increased tubal motility which prevent fertilization of the ovum. Endometrial inflammatory response decreases sperm transport. So if this endometrium is very much inflamed, then that prevents the sperm transports and impedes the ability of sperm to fertilize the ovum. So these are the basis of mechanism of action of IUCD. So there are many different types of IUCD. One variety, so different varieties of IUCD we can see. So it is copper teeth 200, 275, 380A. So why they have, or Mirena that contains the steroid. So first come to this copper teeth 380A. Why 380A? Because it carries total 380 millimeter square surface area of copper. 380 millimeter square of surface area. Okay, so this copper surface area, it is around 380 here. Around the stem, whose surface area is 340 millimeter square. Now at each sleeve there is also a copper. So the sleeve in the horizontal arm, their surface area is 33 millimeter square. So as the total surface area of copper winding round this stem is 380 millimeter square, that's why it is copper T 380A. Now the frame contains barium sulfate, that is radio opaque. This point is very important. This frame is radio opaque, above which this copper wire is surrounding. Now this radio, why it is important? Because if suppose the it has been misplaced, so it has been slipped into the uterus. Okay, so in that case, radiologically, by doing X-ray or by some radiological investigations, we can identify the copper T within the pelvic cavity. Okay, so that we can remove it. So this is important. And replacement is required every 10 years. Why? We are going later to it. So ionized copper has got some additional local infertility. We know that. Then all IUCD, they have a common property. They will cause the endometrial, non-specific endometrial inflammation. They will prevent the entry of sperm. In addition to that, ionized copper, they have they prevent the blastocyst from implantation. So even if the fertilization has happened, they will prevent the blastocyst from implantation through enzymatic interference. And copper initiates the release of cytokines which are cytotoxic. Serum copper level is not increased. It seems that the progressive calcium deposition in the device prevents copper diffusion. So that's why we require the replacement. If it is kept for a longer duration of time, so there will be calcium deposition, so copper release will be prevented. So it should be replaced. Now come to another device. Instead of copper, there we have a steroid, levonorgestrel, that is also known as Mirena. It induces strong and uniform suppression of the endometrium. Okay, and the cervical mucosa, so levonorgestrel, cervical mucus becomes very scanty. Anovulation and insufficient luteal phase activity has also been mentioned. Serum progesterone level is not increased. So this is a kind of form of progesterone. So progesterone, it is a strong and uniform suppressor of endometrium. So cervical mucus becomes very scanty. Anovulation and insufficient luteal phase activity has also been mentioned, as the estrogen activity effect is prevented due to local release of high release of this progesterone, but the serum progesterone level is not increased. The IUCD, they have some definite advantages and disadvantages. So IUCDs, either there may be copper releasing devices or the hormonal releasing devices. They are inexpensive. Copper distributed free of cost through government hospitals. Now, simplicity in techniques of insertion, most cost effective. Prolonged contraception protection after insertion. So once you have inserted it, it will continue for 5 to 10 years, and suitable for the rural population of developing countries. Systemic side effects are nil, suitable for hypertension, breastfeeding women, epileptics, where you cannot use the oral contraceptive pills. Reversibility of fertility is prompt. So if the couple wants the pregnancy, then just removal of the IUCD will suffice. These advantages meet as it is an invasive procedure. You have to insert something, so it requires motivation. Limitations in its use. Adverse local reaction. Sometimes if the hygiene is not properly maintained, so there may be the PID, pelvic pain, heavy periods, okay, and risk of ectopic pregnancy is there. But you can see the failure rate, it is only 0.1 to 200 women here. One important point is that it should not be used in newly married women or women with having any kind of pelvic pathology, because with the pelvic pathology that will be exaggerated. Now come to the oral contraceptive preparations. So their mechanism of action is that they will prevent the ovulation process. We know that ovulation and everything, it is very much hormone dependent. So we usually use the estrogen and progesterone combination. So inhibition of ovulation, both the hormones synergistically act on the hypothalamus-pituitary axis. So in the if in the proliferative phase or in the pre-ovulatory follicular phase, we give local estrogen and progesterone, so they will give a negative feedback on the higher centers, so there will be no LH and FSH, so the follicle formation will be prevented. The release of gonadotropin releasing hormone from the hypothalamus is prevented through a negative feedback mechanism. There is thus no peak release of FSH and LH from the anterior pituitary. So the follicular growth is either not initiated, or if initiated, recruitment does not occur. Now, producing static endometrial hypoplasia, there is stromal edema, decidual reaction and regression of the glands, making endometrium non-receptive for the embryo. So here, from here, we know that this is the site where it will act. Now, another important mechanism is alteration of the character of the cervical mucus, thick, viscid. So if the cervical mucus is thick and viscid, so entry of sperm will be prevented. So probably interferes with the tubal motility and alters tubal transport. Thus, even though accidental breakthrough ovulation occurs, the other mechanisms prevent conception. So their main goal is to prevent the ovulation. So they will act here. They will try to prevent the ovulation. But if accidentally ovulation happens, then they will try other methods. They will make the cervical mucus very thick so the entry of sperm is prevented. So other methods they will try. Now, estrogen inhibits the FSH rise and prevents follicular growth. It is also useful for better cycle control and to prevent breakthrough bleeding. Progestin and ovulatory effect is primarily by inhibiting the LH surge. It is also helpful to counteract the adverse effects of estrogen. We know that oral contraceptive pill containing only estrogen, if it is used for a longer duration of time, there are chances of uterine cancer. In order to prevent it, we use the combination pill that contains the progesterone, because progesterone will prevent this uterine hypertrophy or excitability. So they will counteract the adverse effect of estrogen on the endometrium. So endometrial hyperplasia, heavy withdrawal bleeding, these are the complications. It is also responsible for changes in the cervix. Now this oral contraceptive pill, they have also advantages and disadvantages. They are highly effective, good cycle control, and well tolerated in majority. Additional non-contraceptive benefits are also there. Low dose pill with lipid friendly progestins reduces the risk. Reversibility rate is prompt. But definite disadvantages are there. But now newer generation pills are devoid of these advantages. That is nausea, vomiting, headache due to estrogen, leg cramps due to progesterone, mastalgia due to both estrogen and progesterone, weight gain due to progesterone, cloasma and acne, menstrual abnormalities, hypertension due to estrogen, vascular complications due to estrogen, neoplasia due to estrogen. Now come to the permanent sterilization method, vasectomy or the tubectomy. So we can say one important point here, that even after doing vasectomy, you can say the sperm can reside within the system for 64 days. Okay. So even after doing vasectomy, after vasectomy 3 months, one should take the other contraceptive methods, other contraceptives or additional contraceptive measures in order to prevent the unwanted pregnancy. No one of this single method, they are universally acceptable method. Important factors for the selection of any of these contraceptive methods: for an individual, it depends upon the relative safety. One may be safe for one person, that may not be safe for other. Effectiveness, side effects, and willingness to use the method correctly and consistently. Thank you.